Morning, everybody. My name is Mike Kennedy. I'm a pre-hospital care specialist with Southwest Ontario Regional Based Hospital Program. Joining me is our local medical director for the Central Region, Dr. Matt Davis. Matt?
Hi, everyone. Thanks for joining us today on this webinar. For those of you this first time joining us for a webinar, just so that you know, we will be kind of going through a few ECGs later on in the broadcast. Unfortunately, they will not be amendable to the poll questions that you may be used to previous webinars we get to answer, but we will still present those answers, and you guys can kind of answer on your own there to see if you were correct with your knowledge. We will record this and we will put it on the website as well, so if you want to listen to it at a later time, it will be available down the road. So thank you again for joining us. I think this is one of our largest webinars audiences that we've had, so hopefully we live up to your expectations.
Here's hoping. Okay, so our objectives for the next few minutes, we're going to spend a few minutes talking about ST segment elevation in the setting of both STEMIs and, more importantly for this presentation, mimics. The interesting thing is that STEMI is actually not the most common cause of elevation, so that's what we're going to spend some time talking about now. Most importantly, hopefully kind of take-home useful information will be to provide some tips and tricks on how to clinically apply this to help paramedics improve their accuracy in identifying or differentiating mimics from true STEMI.
Absolutely. And, you know, a lot of anxiety surrounding the ability to interpret ECGs. And like anything in life, it just takes practice. It takes looking at ECG after ECG after ECG in order to become comfortable in determining, you know, causes of ST elevation, but then recognizing the differences between a STEMI and a left bundle branch block. And there are a lot of great resources out there on the internet, social media, blogs, you know, ECG libraries where you can just go and look at ECG after ECG. And like anything in medicine, some of it just comes down to pattern recognition and being able to recognize what a STEMI looks like. And it almost becomes like muscle memory. You look at that ECG and you're like, oh yeah, that is a STEMI versus that is, you know, there's ST elevation, but that is not a STEMI.
And we'll talk about some of those resources towards the end of the presentation, so don't worry about missing out on those. All right, so a few basics about ST elevation. ST elevation can be found in patients both with or without chest pain, so it doesn't necessarily help us differentiate whether these patients are actually having an MI. And interestingly, I think one of the points about this is that MI is actually not the most common cause of elevation. The other tricky thing about this is that identifying STEMI mimics is something that we're probably not all that good at. But like Matt said, the encouraging thing is it really does improve with practice. So we're going to hopefully point you in the direction of some good practice today.
And like Mike says, there's a lot of causes of ST elevation out there. You know, working with residents at an academic center, one of the questions often getting is, name me 15 causes of ST elevation. And as each year they progress through residency, that number just kind of creeps up. You know, starts off at name me 10, name me 12, name me 15, name me 18 causes of ST elevation on the ECG. So there are many causes out there. A lot of them, yep, you may never see the reason why that's causing ST elevation in the pre-hospital setting. But we'll go through some of the more common ST elevation or STEMI mimics here today.
The good thing being we're only going to talk about 3 or 4, not 15. So,
and again, those are the most common causes that we will go over today.
So just to clarify, make sure we're all talking the same language. When we mean a STEMI mimic, we mean something other than an MI that causes ST segment elevation. Hopefully fairly straightforward. There's lots of different types of morphologies of ST segments, and that's what we're going to talk about over the next few minutes. The question I guess you might be asking is, does it really matter if we incorrectly call a mimic a STEMI? Matt, do you have any thoughts on whether over-triage really matters? Is it better to play it safe, or is this really an issue that we need to be concerned about?
Well, definitely it can be an issue when we're overcalling STEMIs. You know, getting patients to the right hospital at the right time. Often requires mobilization of resources, especially at PCI centers. So, we're lucky here with certain hospitals, PCI centers, where the cardiologists actually do get to see or transmitted the ECG and can look at the ECG and agree or disagree with both the computer and paramedic interpretation. But there are some systems where, the PCI team gets activated without actually seeing that ECG. And that does cost the system money. So there are some downsides to falsely activating the STEMI bypass. And again, this may have nothing to do with ST elevation or coronary artery disease. It may have, the ST elevation may be caused by something totally different, and that patient may be served better at the closest hospital, the closest ED.
Matt, I think hyperkalemia or maybe an aneurysm, admittedly both things we're not going to talk about today, but those might be good examples as to where bypassing the local center is not going to be in that patient's best interest.
There's definitely, one cause, which we're not going to get into here, is kind of neurological causes of ST elevation. So definitely catastrophic neurological events or bleeds into the brain can cause ST elevation on the ECG. And again, these patients would be best served at the closest emergency department for stabilization. Again, the ECG is only part of the puzzle. Now, we expect, for a code STEMI to be activated, that the patient needs to be having chest pain first off. So sometimes ST elevations are caused by STEMI mimics, and the patient is actually having no cardiac or respiratory symptoms occurring, which kind of go against this being an ST elevation MI. So again, thinking of the ECG as just another piece of the puzzle. It's looking at the whole picture, not just the ECG itself.
Thanks, Matt. So getting into our full chat on mimics, we mentioned earlier in the broadcast that MI was actually not the most common cause of ST elevation. So interesting here, it looks like from studies done, and this one was done in the early 2000s, that the most prevalent cause of ST elevation is actually left ventricular hypertrophy, or LVH. Next is left bundle branch, or LBB. MI is tied with bundle branch for that. And then following closely after that is benign early repolarization. Interestingly, about 17% of cases in this study, the cause of the ST elevation was also inconclusive. And in addition, the other one we are going to talk about today, although it's a fairly low prevalence at just 1%, is going to be pericarditis. And like Matt said, if you're an emerge resident, you can worry about 15 causes or more. Today we'll focus on about 4.
So I think these are, a good kind of framework as to get your ideas to, there are so many other causes of ST elevation out there, and some of them are more prevalent than acute myocardial infarction. So here's just one study. I'm sure if you were to do another study, those numbers would be a bit different, but this study just elevates that, STEMIs or acute myocardial infarction are usually not the leading cause of ST elevation. So keeping your differential open, and again, looking at the patient as a whole before deciding that you agree with the computer interpretation in terms of this being a STEMI.
So just to recap, we're going to talk about LVH, bundle branch blocks, benign early repolarization, and then a little bit of pericarditis. And then towards the end, we'll point you to some of those resources that Matt alluded to at the beginning of the broadcast. I think it's a natural reaction to say, this seems a little bit intimidating. And I think Matt also said that this is one of the webinars that apparently has a higher number of attendees than we've had in the past. And I think that speaks to the challenge and sometimes the anxiety associated with figuring out this topic. So I'm sure you're all hoping that we're going to give you some practical information, and I hope we are too. I guess that remains to be seen.
Yeah, I think, hopefully you will take away some pearls, some learning points, little tricks of the trade that can help you differentiate ST elevation MIs from STEMI mimics themselves. And again, a lot of that information just comes from the history, past medical history, the patient age itself. It's using that ECG as another part in that puzzle.
I think that's actually the most important piece to take away from this today, is that there's never going to be a history finding, an ECG finding, or any physical exam piece of information that in isolation guarantees the accuracy of your diagnosis. So what we're trying to do is take that clinical correlation, put all these pieces together, add that pattern recognition that Matt talked about, and hopefully use that to improve our accuracy in differentiating STEMI from mimic. The other thing that is maybe interesting is the realization that we don't have to do this in isolation. I think we often feel like we need to make a decision on our own, even though we do work as a crew typically. The good thing is there's two of us, hopefully, at least, most of the time, and consider the computer interpretation as basically a third perspective. If you read the January issue of the newsletter, Dr. Bradford did an article about introducing the concept of an independent double check for ECG reading. So I think we're used to it in the concept of medication safety, verifying what you're seeing, what you're giving, what you're doing with your partner. But I don't think that's something that we often bring into evaluating ECGs. So even though you may be the primary attendant on a particular call, it's very much appropriate, and I would say should become the expectation that you review that ECG together, and that gives two different perspectives and hopefully has the option of mitigating against some of the either distractions that might steer you in the wrong direction. As with most things, two sets of eyes is going to be better than one.
And that's an excellent point, Mike. I mean, you're not working in isolation out there when you're getting these ECGs, and you know, I would want you to kind of, you know what, partner, I think this looks like a STEMI, what do you think? Or this is not a STEMI, here's the ECG, what do you think? A second set of eyes. I mean, when you talk about the whole system of errors, and when errors occur, it's that Swiss cheese model where all the holes have to line up for that error to occur. And here's another opportunity to prevent an error or variance from occurring, is that second check. It happens in the emergency department all the time. You know, we get an ECG, and I'm questioning, wow, this, you know, I know the story. I'll often ask a colleague, hey, take a look at this ECG. What do you think about this? This is what I'm thinking. What do you think? And so there is absolutely no shame in getting that second set of eyes. And again, as Mike said, I refer you to the Links newsletter article where Dr. Bradford quite eloquently describes this process. And I think it's a great idea.
So moving into some of our practical considerations, it makes sense that the data that you get out, or the computer interpretation that we get out in trying to identify STEMIs versus mimics, is only going to be as good as the information that you put into it. So really the key thing in trying to make sure that you get reliable data to make a reliable interpretation is the technical aspects of acquiring that ECG. So things like proper lead placement are really important. Being sure to minimize patient movement and communicate effectively to make sure that they're still as possible to acquire that data for the seconds that it takes. And something that we tend to get a little bit, I don't want to say lazy, but I'm going to say lazy. Something that we could probably do a little bit more effectively is the idea of skin preparation where necessary. So obviously the ECG is only going to be as good as the effort that you put into acquiring it.
And definitely the computer algorithm can be fooled by improper lead placement and by artifact, wandering baseline, and we'll often call these ST elevation when it does see that wandering baseline. Again, it's an algorithm. It doesn't know what the patient's doing. It doesn't know that the patient's moving about in the stretcher. It doesn't know that the patient is covered in hair and the contact between the leads and the skin isn't the greatest. So it doesn't always know this information. So by minimizing these aspects, you will also help the computer identify appropriately STEMIs and identify those that are not. And then again, your set of eyes on that ECG, using that computer algorithm as the third set of eyes, or kind of the screening tool for you. Always look at the ECG. Don't just read it. You know, this is the way you're going to get better at it. Read what the computer says, then you yourself look at that ECG and determine whether or not you agree with it. Show it to your partner. Say, you know, hey partner, this says this is atrial fibrillation. It doesn't say anything about STEMI or ischemia. What do you think? And if you agree with it, then, you know, hey, perfect. And if you disagree with that, that's where the second set of eyes can come in and help with that decision-making process.
We'll spend the next two slides talking a little bit about some basic statistics, although we're not going to wade too far into this. I think the things to consider, most importantly, in addition to sensitivity and specificity, of better interest, I think for us, I'm just actually going to move to the next slide, is the concept of negative predictive value versus positive predictive value. So when it comes to diagnostic testing, if you think about positive predictive value, it's basically the proportion of patients or subjects who have positive test results who are correctly diagnosed. So they do have a condition, being STEMI in our case, and the algorithm accurately identifies that they do have a STEMI. Conversely, the negative predictive value is the proportion of patients who have a negative test value who are correctly diagnosed as not having a STEMI. So no STEMI in reality and no STEMI on ECG.
Yeah, so this is where the whole world of stats comes into play when it comes to the testing within medicine. And every test has a specific sensitivity and specificity, a negative predictive value, a positive predictive value. And this is where the calculations come in when we're looking at the computer algorithms. And this is all kind of comes down to having a test that is able to, the ideal test accurately identifies every patient with that disease and accurately identifies every patient without that disease. That's kind of the perfect test, and unfortunately that is very hard to obtain. So with these algorithms, you're kind of looking for that combination of not being overcalling things, so trying to minimize the number of overcalls, because again, as we discussed earlier, overcalling often leads to other things down the road happening. But at the same time, the biggest thing is you don't want to be missing things. So when it comes down to the algorithms within our computer software for our cardiac monitors and ECG interpretation, what they tend to do is, at the expense of being very able to identify those with the disease, they tend to overcall a little bit. So oftentimes when you get an ECG that doesn't have acute MI suspected or star, ST elevation, myocardial infarction occurring, the way that these algorithms are set up is that it's very unlikely that that is actually a STEMI. So it's going to miss very few STEMIs. But again, the trade-off to that is it will probably overcall things more than it should be. And that's kind of the safe thing of a test, is to tend to overcall. And that's where your interpretation comes in. You're the one who has the patient in front of you, has taken the history, has kind of knows the patient's past medical history, sees the patient in front of you, is hearing that story, hears the description of what is going on, and then using that ECG as a tool to either increase your suspicion, yep, this algorithm is correctly identifying this as a STEMI, I'm looking at it, I agree, this looks like a STEMI, and the patient is there diaphoretic, having an elephant sitting on his chest pain, says it feels like his MI that he had 5 years ago. This is an MI occurring. Versus the patient who, is 21 years old, who is an athlete, who, has been lifting weights and developed some chest pain. And, it's maybe atypical kind of chest pain, but there's enough suspicion you do a 12-lead ECG, and there is some ST elevation on there. And for whatever reason, the computer algorithm says there's ST elevation on here. And then you, as the paramedic, look at this, know the patient in front of you, see that ECG, and say, well, yeah, there is ST elevation on here, but I don't see any reciprocal depressions. And I know that most MIs are going to have reciprocal depression going on. And in keeping with this, this is what's known as a false positive. So here on this table is just kind of just the statistical way of describing this concept to you. And you're looking at the acute MI, so the AMI box there, where the sensitivity and specificity are listed, as well as the positive predictive and negative predictive value. So looking at that negative predictive value of 96%, again, that's telling you that 96% of patients that do have an ECG, which is negative for STEMI, will not be having a STEMI going on. And again, at the expense, well, we need to overcall things. So if it does say STEMI, 88% will be having STEMI. And again, there's all different databases, tests, research out there looking at this, but on average, we're not going to hone down on, oh my gosh, this one is 95, this one says 97. At the end of the day, the take-home message is that it will overcall and will not undercall. Well, it will undercall a little bit, but again, that's where your interpretation and knowing the patient in front of you. And I think with that, what you're faced with in the undercall, you're probably not going to miss any STEMIs.
Thanks, Matt. So to recap that, the two basic take-home points, if the ECG interpretation does not say STEMI, we can be fairly certain that the patient does, in fact, not have a STEMI, that 96 NPV value there. The other thing that we can take away is that for the patient or the ECG that does say STEMI, when you add in that clinical correlation for a patient who has a good history, a good story and physical exam that indicates acute coronary syndrome or ischemic heart disease, that we can also be fairly confident that those patients do in fact have a STEMI. That positive predictive value is pretty high.
Absolutely. I mean, this is just specifically looking at the computer algorithm. 88% is just the computer algorithm. Your clinical judgment and your expertise is going to take that number and bring it up into the 90s, the 96%, the 97%. Excellent point.
Sounds good. Okay, moving on to a little bit of ST segment morphology, and you've probably noticed before that their ST segments can take lots of different shapes, and again, this is another example of hopefully a useful point, but another one that you can't completely hang your hat on in isolation as far as making a decision. So the interesting thing in these ST segments is that the two primary types are going to be concave, the bottom one there, the kind of saddle-shaped or scooped-shaped ST segment, versus the convex one, which is more rounded in an upward direction. So the general rule is that benign ST elevation or non-MI elevation usually presents with that concave or scooped saddled ST segments, whereas the convex or upwardly rounded ST segments more often is indicative of an MI. Again, although there's no guarantees, because MI can on occasion produce ST segments of all kinds of morphologies.
And looking at that top graphic there of the ST elevation, the non-convex, concave or convex, this is kind of what's described as your tombstone. So if you look at that, that has that tombstone appearance, whereas the bottom one, really because of that concave shape, doesn't have that tombstone appearance. Another way you may often hear people talking about, again, I can't keep straight, concave versus convex. One time you did tend to hear people talking about concave up, so looking at the bottom one there, the scoop is facing up, versus concave down, the top one, where that scoop is pointing downwards. So sometimes you may hear people talking about concave up versus concave down, just to help them clarify, because they can't remember convex versus concave. But whatever way you can remember it is absolutely fine. And again, as Mike said, typically those more concerning causes of ST elevation indicating acute coronary syndrome or MI are going to be convex or concave down, the top graphic there.
Thanks, Matt. Next thing we're going to talk about a little bit is correlating reciprocal changes in the setting of MI. I think it's a piece of information that we're hopefully familiar with and have been exposed to before, the concept that in the setting of an MI, anatomically contiguous leads that have ST elevation will often be mirrored by reciprocal changes in anatomically related leads as well. The take-home point being mimics will not produce reciprocal changes, and if you have ST elevation in the setting of a clinically correlated story with reciprocal changes in related leads, you should very much consider that a STEMI.
Absolutely, and again, with that ST depression, I think that computer algorithm, that's not going to be one that it's going to miss. So again, ST elevation with the ST depression, that's kind of the classic hallmark of STEMI occurring. Again, great little table there, again, reminding you of where to expect some reciprocal changes when you are faced with ST elevation.
I think we have a poll question to do there. Do we have those lined up, Steph?
Yeah, we sure do. I hope you can hear me. I have launched the first poll question there to increase some activity here with our learners. So the first question's up, and what leads would you expect reciprocal changes for an inferior STEMI? I'll give you guys a few seconds to answer that one.
I'm not sure about that, so we'll keep going. So we'll get into our specific examples here. So the first one we're going to talk about is left ventricular hypertrophy, or LVH. So we said at the beginning this is actually the most common cause of ST elevation at about a quarter, or 25%. And the way we're going to differentiate LVH from STEMI here is going to be based on a voltage pattern in the QRS. Matt, how do you feel about walking us through this one?
So there's many different ways of calculating LVH. There's many different formulas out there. The expectation is that you don't know each and every one of these formulas. Again, it's a bit of pattern recognition as well. Some simple things to look for LVH are described through step 1, step 2, and step 3. So I think having that idea that with left ventricular hypertrophy, I'm expecting high voltages. So looking at V1 and V5 and adding them together, this is more in keeping with LVH. Having R wave elevation in AVL beyond 11 millimeters is another indication of potential LVH. And again, looking for that strain pattern. As you notice here, you look at this ECG and kind of looking at V1 to V3, it looks a little bit wider there. There's definitely some ST elevation going on there from the baseline itself. And then looking at kind of V5 to V6, you go, oh, wait a second, is that some ST depression going on? Well, that in fact is just repolarization abnormality because of these high voltages. So again, it doesn't have that classic look of ischemic ST depression there that is kind of described as a scooping or strain pattern. Again, the computer algorithms are fairly good at distinguishing left ventricular hypertrophies, but here's some characteristics that you can look for as to determine whether or not this is a STEMI mimic versus a STEMI. And so again, I can't emphasize enough, you do a lot of ECGs out there in the pre-hospital setting. They're valuable too, and I can't stress enough how valuable they are to us as emergency physicians. So, you're doing quite a few of them as your day goes on. Look at each and every one, and if the computer algorithm does say LVH, the way you're going to get good at interpreting LVH is saying, okay, why is this LVH? And then going back and looking at that ECG and noticing this pattern of LVH. Again, when it comes to voltage criteria, as I say, there's many different voltage criteria out there. It's kind of knowing a few of them and just using that to help you determine is this LVH or not. And again, the only way to get good at this stuff is just to keep looking at ECGs, doing online modules looking at ECGs.
And the key to this is the fact that it's a package deal or a bundle deal, that to reliably identify LVH versus STEMI, all three of these criteria have to be met, and you can't rule out a STEMI just by meeting one or two of these criteria. Next one we're going to have a look at is a left bundle branch block, one that can give people a decent amount of grief, I think, in determining, and is also a high prevalence rate in the neighborhood of 15%, I think, of causes of ST elevation. So a couple things to look at here, kind of a four-step approach again, and again basically a package deal. So the first thing you're going to look at is the QRS duration in V1. We're familiar with the standard measurement being about 120 milliseconds. So we're looking for a QRS in the setting of a bundle branch block that's going to be wider than normal, wider than that 120 milliseconds. Second, you're going to look for a notched R wave, kind of a bunny ear R wave, you may hear it referred to, in AVL and then down in V5 and V6. Third point you're going to look for is an absence of Q waves in those same leads, AVL, V5, and V6. And then again in step 4, referring to that notched or prolonged R wave again in V5 and V6. So it's going to be, instead of a nice clear point like you would typically see, it is going to be something that's extended basically over half the duration, or over half, or over 60 milliseconds in the QRS complex.
Again, the presence of a left bundle branch block is an exclusion to many of our local protocols in terms of transporting to the PCI center. And anecdotally speaking, the ECGs that I do review, the computers are pretty good at interpreting the left bundle branch block, but what they're not very good at is, once recognizing this, is saying that this ST elevation is related to that left bundle branch block. So I think that's where the majority of our false positives do come from. So false positive meaning the ECG is saying that this is a STEMI when in fact a STEMI is not occurring. So again, it's very good at determining left bundle branch block. So if your ECG does indicate a left bundle branch block is occurring yet says STEMI, this is 99.9% of the time, this is going to be an exclusion from the PCI center, and this is going to be transport to the closest hospital. Again, some of you may have heard about criteria, because people with left bundle branch blocks definitely can have STEMIs, and some of you may have heard about Scarboza's criteria. However, that's not an expectation from us at Base Hospital. From the BLS PCS is recognizing Scarboza's criteria. You'd never be faulted for not recognizing an MI in the setting of a left bundle branch block. And so, again, for those who want a bit more of a challenge and want to go and read more about this, then there are some good resources out there where you can kind of look at Scarboza's criteria and determine if someone with a left bundle branch is potentially having an acute MI. But again, that goes beyond the expectation, and the protocol does exclude patients with a left bundle branch block from STEMI bypass.
Thanks, Matt. I think our approach as paramedics in the past has often been in the setting of left bundle branch block. It's really difficult to identify whether patients are having an MI or not, and these criteria do go a long way in helping us realize that there is a way to kind of identify acute ischemic events from kind of long-standing or at least previously occurring damage or bundle branch blocks. So if you are one of those people that's motivated to look for a little deeper challenge, this is one of those ones that once it clicks is actually really useful in a lot of different settings there, as it mentions not only left bundle branch blocks, but paced patients, right bundles as well as both right and left ventricular hypertrophy.
And Mike, can you just go back to that the slide there showing the left bundle branch block there as well? Again, I cannot stress this enough. It's kind of the muscle memory that occurs when you see ECG after ECG after ECG, and when you don't have that experience, you kind of look at this ECG first glance, you say, wow, this looks absolutely ugly. Look at this ST elevation. Looks like there's flip T waves. But again, more and more ECGs that you do, it becomes almost pattern recognition, where that can flash up in front of you, and you can, within 2 seconds, look at this and say, this is a left bundle branch block. So again, the old adage, practice makes perfect. It's absolutely true, and you're just training that muscle memory to be able to look at these ECGs and notice the pattern recognitions. And that's what a lot of ECG interpretation is. It's exactly just pattern recognition, and by practicing, you train your brain to see these patterns and be able to quickly diagnose things.
Thanks, Matt. So moving on from bundle branch blocks, we're going to spend a little bit of time talking about benign early repolarization. Some similar findings here for BER as well as pericarditis that we're going to talk about next. So the kind of 4 primary observations that we're looking for are summarized on the side there. Starting with the J point, or the point where the ST segment comes off the QRS complex, you're going to see a fairly distinct notching or fishhook pattern there. The second thing that you're going to be looking for, coming back to concave versus convex ST elevation, this is going to be another setting where you're going to find that concave or saddle-shaped, scooped-shaped ST segments, and they're going to be most common basically on the right side of the ECG printout, or in the I guess that's counterintuitive, the left precordial leads, the V2 to V5. On the right side of the ECG is a bit of a misnomer, so I apologize for that. The thing to take away is that they're very rarely going to happen in isolation in the limb leads. It is going to be especially a precordial focus. Next thing we're going to be looking for is a prominent and slightly asymmetrical T wave that is concordant or goes in the same direction as the QRS complexes. So if you have an upright QRS or positive QRS, that T wave will also be positive or concordant with that complex. And then the next thing to think about is basically the degree of elevation, ST elevation that's present. It's going to be typically fairly moderate or modest, in the sense that it's not usually greater than 25% of the T wave. So if you do have ST elevation that is over 25%, and again that's going to be a rough guideline, certainly if you have ST elevation that's basically as high as the T wave, that's going to be probably pointing away from benign early repolarization and pointing more towards STEMI.
And again, as this graphic displays, these are the classic finding of benign early repolarization. Unfortunately, not every patient is going to have all four. Some are going to have variants of this. But again, a piece of the puzzle. It's the patient there in front of you. Again, with benign early repolarization tends to be a younger patient subset that tends to have this entity going on. So more common in your 20, 30, 40-year-olds versus your 70, 80, 90-year-olds there as well. So just something to keep in mind.
That perfectly drives home the points on that slide. I think that in identifying a patient with risk factors and a good story for ACS, especially when they're over 50, benign early repolarization is probably not a prudent conclusion to come to.
And again, looking at this ECG here, you know, factors that, oh, you first glance at it, you may say, yep, look at that ST elevation. I see ST elevation in 1, 2, something going on there in AVF, and then looking kind of, oh, starting in V2 all the way to V6. But again, looking for those reciprocal depressions. Are there reciprocal depressions going on? And they don't see any true reciprocal depression. So, you know, there's very few ischemic causes of widespread ST elevation across all leads in the ECG. But then going back to other factors, okay, well, you describe that little J notch, and again, looking at V4, V5, V6, you see that little J notch there, which kind of goes against ST elevation MI. The convex up kind of approach, or that scoop facing up on these ST elevations, goes against this being ischemia as the cause of ST elevation. And the thing in front of you, the patient, looking at the patient, knowing the story, knowing the risk factors, knowing the age, putting this all together and saying, you know what, this is benign early repolarization, this is not an MI occurring. So we just had a question come in, and the question is, pace rhythms mimic a bundle branch block if it's ventricular paced, which I totally agree with. So how does STEMI identification with a patient with a known pacer, even if heart chamber that is being paced is unknown? So the way a pacer works is they do mimic a left bundle branch block, and kind of understanding the physiology behind what a left bundle branch block is. And going back to your anatomy, you know the electrical signal comes down through the SA node, the AV node, and down through the left and right bundle branch block, or sorry, the left bundle branch. And it typically, the heart typically depolarizes from left to right. And so that's what gives us our kind of normal looking ECG. However, when that left bundle is actually blocked, the signal goes down only the right bundle branch. And what occurs is that left side of the heart still gets depolarized. However, it takes longer because that signal needs to come from the right side of the heart. And that's what gives us our characteristic look of that left bundle branch block. Now, pacemakers work in the exact same way. So the pacer is inserted, you have a lead that goes down into the right ventricle, and that's how the heart is depolarized. It's depolarized from the right to the left. And so patients that have a pacer tend to have morphology that looks exactly like a left bundle branch block. In fact, it's often even more pronounced than what you would see with a left bundle branch block. So those same kind of characteristics that you see with a left bundle branch block. And oftentimes the computer algorithms will recognize this and suggest that the patient is paced. At the very least, it does recognize this as a left bundle branch block. So determining patients who have a pacer in situ, who are having MI, again, becomes very difficult because their ST elevation is going to be masked by their underlying ST elevation from their pacemaker. And as Mike alluded to, there are certain criteria that you can put into place, known as the Scarboza criteria, to help differentiate benign, meaning non-worrisome ST elevation in these patients, versus some worrisome. And again, this goes beyond the scope of what is expected. And if you do want to take it to that next level, then I do encourage you to go out and read about Scarboza's criteria and to be able to determine potential causes of, potential ECG changes that are indicative of STEMI in the presence of left bundle branch block. But again, from a protocol standpoint, left bundle branch blocks exclude patients from STEMI bypass. And again, ventricular rhythms are going to give you that same left bundle branch block. So if the computer algorithm is going to read it as a left bundle branch block, and they would subsequently be excluded as well.
That's great, Matt. Thanks. The last kind of clinical area that we're going to look at is a consider of pericarditis. We mentioned that it was only about 1% of the causes of ST elevation, but anecdotally it seems to be one that we feel like we potentially come across on occasion in the pre-hospital setting. So what is pericarditis? You can certainly read for yourself there. We're familiar with it being an inflammation of the lining of the heart. And some of these patients can look quite unwell. They can be tachycardic, they can be short of breath. There's often specific characteristics as far as positioning and things like that aggravate or alleviate pain. The common finding, though, tends to be widespread ST segment changes basically across the ECG without typical anatomical groupings of that ST elevation. If you do see ST changes that are isolated to typical anatomically contiguous leads, and especially if there are reciprocal changes associated with STEMI, with that elevation, then you should definitely again be thinking STEMI versus pericarditis. This is exactly where that clinical correlation, trying to identify history, probably going to be especially important, not especially important because it's always especially important, but important in evaluating these patients and trying to differentiate STEMI from pericarditis.
So excellent overview there, Mike. You know, if only patients could read all the rule books and present classically as they should. The thing about pericarditis is it has evolving ECG changes. So you can have a completely normal ECG and have signs of pericarditis, but over time that ECG does evolve. So it often depends at what point in their disease process that you're seeing them and getting that ECG will you have specific characteristics on that ECG. So again, as Mike said, another cause of ST elevation, and I believe we'll go over a couple of pointers of other things that we can recognize pericarditis from ischemic ST elevation there as well. The thing about pericarditis is an inflammation of the lining of the heart, the pericardium, and it's an inflammatory process. It's fairly benign. We treat these patients with anti-inflammatories, so often NSAIDs. Sometimes we'll use steroids as well to settle down this inflammation, and the biggest pathology that it causes is just unfortunately discomfort in our patients. But Mike also described patients who present with pericarditis-like findings on their ECG history who look quite unwell. And these are sicker patients, definitely, and this is what is referred to as myocarditis. So the inflammation has extended to the myocardium. The most common causes of myocarditis often are viral. And this is when we see those sicker patients and may have some ST elevation as well. But again, the story behind that is often these people have been unwell for a while and they've had trouble breathing and some chest pain and shortness of breath and describe a prodromal illness of what they thought was influenza, and now they're you listen to their lungs and they have crackles on both sides and they're febrile and they've got chest pain and they're short of breath and they're hypoxic. Again, these are putting everything into context and looking at these patients. So there's that spectrum of pericarditis, benign to myocarditis, which are very sick patients.
Thanks, Matt. So that's a really quick and dirty review of some of those key STEMI mimics. Like Matt said at the beginning, there's all kinds of them. Whether the elevation mnemonic does anything for you or not, there's a list of some of the other causes of ST elevation, again with varying degrees of prevalency. And at the bottom there you also see a couple of resources that we've alluded to. Life in the Fast Lane is a great, comprehensive, free, open access resource with all kinds of examples and correlating information for ECGs.
That's a great website. It's got a huge ECG library with tons of ECGs that you can look at, but it also describes in a very, I think, straightforward, succinct fashion as to what to look for, what these changes are, what the criteria are. So it's a great resource, one that I often use a lot to pull out teaching ECGs from, as well as helping prepare for lectures to medical students, to our residents, for our paramedics. So
this webinar.
It's a great resource, and it's one that definitely has a seal of approval from my end. So if you are familiar with it, then I'm sure you'd probably agree, and if you aren't, it would be one to take a look at. fresh out of Australia, so you can read it in an Australian accent if you want.
The next one listed there is Dr. Smith's ECG blog. It's an emergency physician out of Minneapolis who I would say is probably easily becoming one of the kind of gurus in ECG in this day and age, and has provided a lot as far as evaluation and alterations to things like Scarbos' original criteria. If you want a PhD in ECG interpretation, although not everything is incredibly complex, this is certainly a good resource, again, with lots of examples about all kinds of interesting pathology available on ECG, so another good resource.
And I definitely see that one on social media being passed around in examples and cases. I'm not as familiar with Dr. Smith's ECG blog, and a little off topic here, but again, when we're talking about resources and free open access medical education, there is so much out there, and I think the downfall to it is you can almost get bogged down into being overwhelmed with the amount of information that's out there. And at the end of the day, you do have to be a critical appraiser of what you're reading. It has to come from a reputable source, but find one that jives with you and stick with it. Don't feel the need, I've got to go to Life and Fast, I need to go to Dr. Smith, I got to go to Amo Matsu and see all his cases. Pick one that works for you and stick with that.
Good advice, Matt. Thanks. I believe we've got a poll question now.
So we do have the next poll question up. Question is, what is the most common cause of a false positive STEMI? And your options up there are left ventricular hypertrophy, pericarditis, benign early repolarization, or a bundle branch block. So we'll give you a little bit of time to answer that, and then we'll get right back into the presentation. All right, so it looks like we've got 76% of the audience picking left ventricular hypertrophy.
Okay, thanks folks. I have no idea what the poll results were, but hopefully they're good. Before we get into a couple of practice ECGs, just to try and drive home what we have been talking about, a couple of things to wrap up all these practical implications. Matt, I'll take the first couple. You want to take the bottom half of the list? So things that we hopefully drove home effectively, including in your recertification or mandatory CME this year, are the importance of early 12 leads, and that ideally means pre-intervention 12 leads. We know that these 12 leads are very dynamic and can change fairly quickly based on some of the interventions that we do, including oxygen and nitro. And so having that baseline is really important, and as the research that's been done even locally by Dr. Davis and Dr. Llewell, that early pre-hospital 12 lead often comes into play in determining the final disposition or management of the patients in the emergency department. The next thing you want to look at is, are there actually ST segment or T wave changes? You can think about morphology, scooped versus not. How profound are they? Does it seem to be fairly minor, or is it quite significant, maybe over 25% in the setting of that pericarditis one that we talked about? Another key thing is, are there reciprocal changes? If you do have kind of related reciprocal changes with that ST elevation, that's basically a sure thing that this patient is going to be STEMI. Again, taking that into the clinical context. And then finally, what is both? We've got computer interpretation say, but what does your partner say as well? What are the things that we've, as kind of the three interpretations, do we come to some consensus, and which direction does it point us?
Again, I think we've stressed throughout this webinar, the correlation, so that the patient in front of you, does this ECG make sense in the setting that it's been taken in? Kind of, going through medical school and going through your cardiology rotations, cardiologists would just throw up the ECG, no clinical context, interpret this, and that's not how we work in the real world. We know the clinical context behind these ECGs, and that is huge when it comes to interpretation. It helps shape what you're looking for in that ECG. So again, we stressed it, the ECG, just one piece of the puzzle itself. Again, ensuring that you're obtaining the best possible 12 lead that you can, ensuring, because again, the computer is going to overcall things when there's a wandering baseline. It's going to overcall things when there's artifact, and interpret that as ST elevation. So obtaining the best quality ECG as you can will help the computer algorithm in interpreting that ECG, but also help you in interpreting that ECG as well, because you won't have the wandering baseline to deal with. Things get missed in a wandering baseline, and there may be, ST elevation present that the computer doesn't realize it in the leftward leads V4 to V6, but if you have a wandering baseline, it's all over the place. It may be difficult to see this. Again, obtaining serial ECGs to confirm diagnosis. ACS is an evolving entity. When you first get there, they may have signs and symptoms consistent with myocardial infarction, and you get your 12-lead ECG and it looks normal, but they've got the story for it. Again, we've stressed at our certification day kind of opportunities that you do have in the pre-hospital setting to get those serial ECGs. And again, this is an evolving process, and what sounds like STEMI, but ECG doesn't show STEMI, may evolve into one, so another important aspect of it as well. Again, communicating your findings to the receiving staff. Mike kind of mentioned this, and I think I may be a bit biased in this regard, but the pre-hospital ECG beyond STEMI is a super valuable tool, and I cannot stress enough how important it is for us as emergency physicians, how important it is for your patients that these ECGs be handed over. And if you do notice something like significant ST depression on that ECG, make it known to the triage nurse when you're handing over the care. Show that ECG. We try to pass on that importance to our nursing staff about how important the pre-hospital ECG is. And often these changes that occur in the pre-hospital setting, we're not capturing in the emergency department. So again, another important tool for that pre-hospital ECG, and a way that your care in that pre-hospital setting is actually making a difference. And things could be missed in the emergency department if we don't have these pre-hospital ECGs, so a super valuable tool. And again, we've kind of gone all of these resources, and I encourage you just to keep practicing, keep looking at ECGs, and this is the only way that you're going to get better at this, is just keep looking at those ECGs.
Matt, back to your point about communicating to making sure that's available for the physician. Hopefully we drove the point home again in research that it's really important. Not everybody in the kind of chain of care may appreciate the significance of that pre-intervention, pre-hospital 12-lead that you did. So trying to make sure that you can get it into the chart, ideally in a hard copy, paper copy, to make sure it is available for the physician. So write a name on it, give it to the clerk and say, hey, I got a chart or an ECG for bed 3. Can you put it in the chart? And that'll make sure when Matt or whoever the emerge doc comes along has that information actually available to help make their decisions. We're going to move into a couple of practice things here to hopefully drive home the points that we've talked about. Sounds like on the last poll question that we did, 76% got it right. The answer was LVH, and hopefully we'll reinforce that as we move through the next ones. So I believe we have, we'll let you look at the ECG for about 10 seconds or so. You can't actually poll at the moment, but those are going to be the answers in the bottom corner there. I'll give you 10 seconds or so, and then Steph can open the poll questions there, and we'll get some sense of what kind of track we're on.
Okay, so we're hoping you've had enough of a look
at. Here's the computer algorithm saying this meets ST elevation MI criteria. So as soon as I see that, I'm going to be like, okay, can I agree with this interpretation, or is there something else going on here which is not in keeping with that interpretation? And again, very difficult. We haven't provided you any clinical context with which this ECG has been taken in, but we want to challenge you a bit more just to use your ECG interpretation skills here today. So take a minute and put your vote in.
So our apologies, guys. It seems we're having some technical
difficulties. These are actual ECGs that have occurred in our region, so these are our real-world examples.
So it looks like we've got a pretty even split there. We've got highest answer of about 40% being LVH, 20%, actually 31% at STEMI, 21% for benign early repolarization, and 7% for left bundle branch block. Matt, do you want to give us your thoughts on your take on this ECG?
So again, looking at some features of this ECG, the first thing I notice is that there's pretty diffuse ST elevation across all leads. Definitely the inferior leads, I see some ST elevation, 2, 3, AVF, And then kind of looking at the precordial leads, a bit of a wandering baseline there in V3. You can see how the line doesn't connect there. So there was some kind of movement at some point, which gives that first complex a bit of a unique look to it compared to its predecessor and the one preceding it there as well. But then I extend over into V5 and V6, and again I see a little bit of ST elevation there as well. The one thing I don't notice on this ECG is any signs of ST depression. So that starts to make me think, okay, is this truly an MI occurring? I don't see any reciprocal changes occurring, and it'd be a very odd pattern to have. You know, this would be kind of an inferior lateral type of ST elevation, so I'd expect to see some kind of reciprocal changes, which I don't here. Kind of honing down on it more, again, we talked about the little J point, and if you look very closely at V4 and V6, you can kind of see a little bit of that notch in there as the ST segment takes off. So again, that was something we discussed about benign early repolarization. Again, the other thing I noticed, this patient is 49, so kind of falls in that younger age category. Again, as a paramedic, I would look at this ECG in the context of the patient in front of me, and you know, depending on the story, if this guy has an ischemic type of story, and you look at this ECG and the computer says this is ST elevation, your glance, you look at it, then you know, if your clinical judgment says this is a STEMI, then by all means you can get in contact with the PCI center, or you implement your local bypass protocol. But again, there's features that go against this being STEMI, and based on all of those features, this is actually benign early repolarization occurring.
Thanks, Matt. Here's the next example we're going to look at, so have a look at that for a few seconds, and then we'll open up the poll and see what our thoughts are on this one.
And again, the computer algorithm has identified this as meeting ST elevation MI criteria, along with some other information which it thinks is occurring. Also says demand pacing, which is very interesting.
I think the most interesting piece about this ECG is basically the poor data quality. Like I said, this one doesn't actually identify the fact that the poor data quality may impact the interpretation or the computer interpretation of the information. But this is one of those areas where the acquisition of the ECG, trying to get as good quality information as possible to make that determination is key here. Given the amount of artifact and the interesting findings there, including the pacing, ST elevation, etc., we're going to say this is going to be none of the above based on the artifact associated with this ECG, and we need to try harder to get a better quality ECG. Okay. Understanding that's a bit challenging sometimes.
94% of the audience recognizing this, and again, so why is this calling this ST elevation? Well, again, with that artifact, the computer is being tricked and looking at, it can't discern what the ST segment is. It potentially is looking at a couple of those PVCs and saying that's what the ST elevation is. When it comes to demand pacing, it's seeing all these artifacts, which is causing all these tiny waves in here. It's thinking that these are pacing spikes. But again, you know, looking at these complexes, this is definitely not a wide complex, which we'd expect with a demand or a pacemaker in situ. So again, this is a STEMI mimic based on the poor quality ECG.
Thanks, Matt. I know we're starting to run a few minutes over time. We've got a couple more ECGs we'll wrap up, and then we can carry on about our day. So again, here's another ECG that the computer has interpreted as a STEMI. See what you think about that, and we'll open up the poll in a sec. So looks like we've got about 83% there correctly identifying STEMI. Some of the things to kind of focus in on here, looks like you've got some fairly profound elevation in the inferior leads, 2, 3, and AVF. And you've also got some corresponding reciprocal changes in AVL, as well as your anterior leads. So good call on identifying that as STEMI. Any other thoughts there, Matt? You good with that one?
That's an excellent job. Yeah, we have 85% identifying that as STEMI there. Again, looking at this, there's definitely the reciprocal changes we'd expect to see. And again, as I've alluded to before, not everyone reads the textbook, and you look at these ST elevation segments, and unfortunately they don't have that concave down type of appearance, and they actually almost look like a concave up type of appearance. So again, just one piece of the puzzle, just because it's that way does not mean it's STEMI. It's looking at all these pieces of the puzzle and putting them together. So in this case, I agree this is inferolateral STEMI going on with appropriate reciprocal changes, potentially some, ischemic changes in V2, V3, reciprocal changes versus is this potentially extension to the right side versus a posterior MI as well.
Thanks. Second last one. Can open up the poll and we'll have a look at our thoughts on whether this is STEMI or not.
Looking through the computer algorithm, and the question is, do I agree or disagree with that? And it's saying, well, I should be considering an acute infarct, and so I will consider acute infarct and try to determine, is the computer algorithm right, or am I going to be the clinician and disagree with that computer?
So it looks like we've got about 64% identified this as VTAC correctly, with left bundle branch being kind of the most common other choice for mimic or flag there. Any thoughts, Matt, on, I guess, for the people that identified it correctly as VT, the next question is, do they have a pulse or not? And that'll decide our treatment from there. But
if there's a 12-lead ECG, I hope they have a pulse.
I just thought he was quiet.
Again, could the patient be having a STEMI? Absolutely, the patient could be having a STEMI in this situation. VTAC can occur in the setting of STEMI. However, based on this ECG, we don't have criteria to say that STEMI is occurring because this is actually ventricular tachycardia. And you look at the heart rate, 172. 85-year-olds cannot get their heart rate up to 172 unless something bad's going on. In this case, we have ventricular tachycardia occurring. So this patient would be needed to be transported to the closest emergency department for stabilization for our PCP colleagues and for our ACP colleagues. And of course, you can use your scope of practice to treat the patient in the pre-hospital setting.
Thanks, Matt. Our last ECG to sum up our webinar for the day. Give you a few seconds there to review. Sorry, I can't actually hear what Steph's saying, but so it looks like we've got about 80% identified this as a left bundle branch block, with STEMI being the other most common choice. So certainly highlights the challenges and difficulties sometimes associated with differentiating left bundle from STEMI.
So again, yeah, features that go against STEMI, and more in keeping with the left bundle branch block. First off, this has a wide QRS complex and calculated QRS of 0.184, so definitely wide. Has those features of a left bundle branch block, being in V1, mainly a negative deflection with that S wave there. There is ST elevation, I agree, But looking at what's probably perceived for those who thought this was STEMI as what is thought to be ST depression. And I mean, ST depression is a bit of a kind of an overarching term, and yes, the ST segment does depress below the baseline, but this is kind of what's seen in that strain pattern or repolarization abnormality. So going back to those features which Mike alluded to, kind of meaning negative deflection in your rightward leads, so your right more precordial leads, V1, V2, versus that widen potential RR prime and V6 with that scooped ST depression or strain pattern in those leads is more in keeping with a left bundle branch block. So again, the computer has been fooled into thinking that this is a STEMI occurring, and this is where you again use the patient in front of you, the clinical correlation, as well as some of these features to help discern whether or not this is a left bundle branch block versus a STEMI. And again, the computer rightly calls it a left bundle branch block. So with our protocols in play, this patient would be excluded from a PCI center, PCI bypass.
That's great, Matt. Thanks. I think that's the information we have to deliver today, so I thank everybody for your time. If you had some challenges in identifying those ECGs, don't be disheartened. It does take a lot of regular repetitive practice to develop your skills with this. So think about some of the resources we've offered, talk about it with your partners, look at the ECGs and evaluating those ECGs and trying to identify when the computer does make an interpretation, see if you see what it sees, and over time you'll further develop your skills. Thanks.
Thank you, everyone.